Hey guys, this is Dr. Hub. In case you haven't subscribed, please do subscribe to learn and grow daily. Now we're going to focus on the CVS system. We'll try covering the most important questions. So this is going to be only the important questions. The first thing in CVS is we need to identify the ECGs. And the important ECGs to identify include the ventricular tachycardia. There is also the ventricular flutter. So we need to distinguish between the three. So ventricular flutter. Next, there is also the ventricular fibrillations, which also needs to be differentiated from. Next comes there is a syndrome known as the WPW syndrome. So what is the WPW syndrome? It is nothing but characterized by there is an abnormal accessory pathway. So there is an abnormal accessory pathway. So abnormal accessory pathway in the heart, and it leads to the arrhythmias. Now let's look at the ECG changes. So WP syndrome is what we discussed, and the ECG changes, it includes the shortened PR interval. So WPW syndrome has a short PR interval. So short PR interval. Next will be the prolonged QRS. So there is prolonged QRS duration. Next is the presence of the delta waves. So there is also presence of the delta waves. So how do you treat this condition of the WPW syndrome? The treatment is there is a cardiac ablation which can be done. Antiarrhythmic drugs such as the procainamide, amiodarone, and quinidine. Next, the IV procainamide is a drug of choice in case of hemodynamically stable WPW, which presents with the atrial fibrillation. So important drug being the IV procainamide. And in case of the DC cardioversion, it can be done. And this is basically with the hemodynamically unstable patients. Next, we move on to the JVP and the abnormalities. So here, this is how roughly the JVP looks. So you have the A wave, C wave, X, V, and Y. And here, what are everything corresponding to? So A wave stands for the atrial contraction. A is for the atrial contraction. Next is the C wave. The C wave stands for the bulging of the tricuspid valve. So bulge of the tricuspid valve. Then comes the X descent. The X descent, it stands for the atrial relaxation. So you have the atrial relaxation. Then comes the V wave. The V wave stands for the venous filling of the right atrium. Then comes the Y descent. So Y descent is for the passive emptying into the of the right atrium. So passive emptying. So passive emptying of the right atrium, and this is into the right ventricle. Now let's look at each conditions. So going on to the A wave. A wave is nothing but it corresponds to the atrial contraction. So you have a different waves, that is you have a prominent A wave. Next you can have canon A waves. Then you also have the absent A waves. So prominent A waves are present in case of the pulmonary hypertension. They can be right atrial thrombosis of mass or the tricuspid stenosis. Now looking at the canon A waves. The canon A waves are seen in cases of the complete AV block. So complete AV block that can be seen in ventricular tachycardia, the premature atrial junctional, as well as the ventricular beats. Next is the absent A waves. This is important. The absent A waves are seen in the atrial fibrillation. So atrial fibrillation has the absence of the A waves. Next, so what was the A wave about? A wave was about the atrial contractions, and we saw the three headings, that is the prominent A waves, the canon A waves, as well as the absent A waves. Next we move on to the C wave. So this C wave is nothing but it corresponds to the bulging of the tricuspid valve into the right atrium. So bulge of the tricuspid valve into the right atrium. So bulging of the tricuspid valve in the right atrium, this is during the ventricular contraction. Next was the X descent. So there is the X descent. X descent corresponds to the atrial relaxation. So AR, the atrial relaxation, and this is during the atrial diastole. So what are the abnormalities? You can have a absent X descent as well as a rapid X descent. So you have absent as well as the rapid. So in cases of the absent X descent, it is nothing but the severe tricuspid regurgitation, and in cases of the rapid X descent, it is nothing but the cardiac tamponade. Next we move on to the T waves. So what is this T wave about? So V wave is the venous filling of the right atrium. So V wave corresponds to the venous filling, V for V and V for venous. So venous filling of the right atrium. So there can be a dominant V wave. So this dominant V wave is nothing but the tricuspid regurgitation, that is a TR. Next we move on to something known as the Y descent. So what happens in the Y descent? So here in the Y descent, it corresponds to the passive emptying of the right atrium. So there is a right atrium and there is passive emptying of it. So that is nothing but the Y descent. So here in Y descent, it is again the prominent Y descent. There can be a rapid Y descent as well as a absent Y descent. So in case of prolonged Y descent, it is the tricuspid stenosis. Next, in case of the rapid Y descent, it is the constrictive pericarditis. So let's change the symbol. So this can be descent. So the rapid descent is nothing but the constrictive pericarditis. We are writing it as CP, and also the isolated severe tricuspid regurgitation. So what is the absent Y descent? The absent Y descent is nothing but standing for the cardiac tamponade. Next, moving on, we also need to know some important drugs used in heart failures. So we'll just quickly glance through it. So in case of heart failure, in case of the acute decompensated heart failure, you have the IV vasodilators. So to name a few, you have the nitroglycerin, sodium nitroprusside. So all this, it helps in the decrease in the preload as well as the afterload. Next, there is also the nesiritide. So this is a recombinant human BNP. Next, there is also the IV for positive inotropes and the drugs for rapid symptomatic relief. So let's look at the drugs for the rapid symptomatic reliefs. Drugs for the rapid symptomatic relief. So in case of the rapid symptomatic relief, there is the bumetanide, the furosemide, the torsemide. So let's look at it. There is a bumetanide. So there is the bumetanide. There is also the furosemide as well as the torsemide. So bumetanide, furosemide, torsemide, they are nothing but the loop diuretics. So they are LD, the loop diuretics, used for the symptomatic treatment of severe heart failure as well as the acute decompensation. Next, we also look at the morphine. The morphine is nothing but the opioid to calm the patients and decrease the cardiac O2 consumption. So decrease in the cardiac O2 consumption. So then we also earlier spoke about the IV positive inotropes. This includes the dobutamine, dopamine, epinephrine, norepinephrine. They are nothing but the B1 receptor. So let's quickly highlight them as well. So dopamine, dobutamine, the epinephrine, norepinephrine, they are nothing but the B1 receptor mediated stimulation of cardiac output. Next, we have the enoximone and the milrinone. They are nothing but the PDE 3 or 4 inhibitors. Next, the levosimendan, the pimovimdan. So the pimobendan, all these are the combined calcium sensitizers and are nothing but the PDE3 inhibitors. Next, moving ahead, let's look at, this is very very important, that is we need to know how the high quality CPR is. So for the high quality CPR, you need to push hard, that is about 5 to 6 centimeters, and depth. Next is push fast. Push hard is this much. Push fast, that is about 100 to 120 BPM. 120 is the rate we need to push fast, that is the frequency. Next is allow complete chest recoil. So allow the chest recoil. Next is avoid the excess ventilation and rotate the compressor every 2 minutes. So if no advanced airway, 30 to 20 compression ventilation ratio. So there is a 30 to 2 compression ventilation ratio. So you need to improve the quality of CPR in certain conditions. So what are these conditions? So the conditions include, so improve in case of the quantitative waveform capnography, that is a PET-CO2 that is less than 10 mmmHg. Next is in case of the IAP, that is the arterial pressure, if the relaxation phase, that is the diastolic pressure, is less than 20 mmHg. So this was about giving a high quality CPR. Next, let's quickly look at the venous thromboembolism. So we have the venous thromboembolism. So this venous thromboembolism, risk factors, it includes in cases of major trauma, also in cases of the surgery of the hip or the knee, the major joints, then hospitalization for the heart failure or the atrial fibrillation within the last 3 months if you are hospitalized. Then in case of the myocardial infarction, then the previous venous thromboembolism, and in case of autoimmune diseases like lupus as well as the antiphospholipid antibody, inherited thrombophilias, the hypercoagulable state as well as iatrogenic. Then comes the varicose veins as well. So all these conditions. Next we are going to look at the, so we need to know about the familial dyslipidemias as well, and let's quickly highlight on the revised Jones criteria. So this is important. So this revised Jones criteria for diagnosis of rheumatic fever is there are a major and minor criteria, and it is different for the low risk as well as the high risk population. So first let's look at the low risk populations. And so in case of the low risk populations is we have the carditis. So this is nothing but the major criteria. So let's write major so it's easier. So in case of low risk population, there is a carditis as well as there is arthritis. So all itis comes here, inflammation, carditis, arthritis. So in case of low risk, we are highlighting only the polyarthritis. The same thing, let's look at the high risk. So in case of high risk, previously the carditis, it is clinical and subclinical. Here let's write the major criteria, that is in major high risk populations there is polyarthritis, also the polyarthralgia, also there is a monoarthritis. Next is we also have the presence of the chorea. So this is in both the major and the minor criteria. There is chorea as well as there is the erythema marginatum. Next there is also the subcutaneous nodules. There is subcutaneous nodules. So this is about the major criteria. Now quickly jumping on to the minor criteria. So what is happening in the minor criteria? So here in case of the minor criteria, there is the polyarthralgia as well as the monoarthralgia. So we have the low risk, and let's divide it by the high risk, and in case it is common, we are going to write it in between. So in case of the minor criteria in the low risk, it is going to be the polyarthralgia. So this is the polyarthralgia. And in case of the high risk population, it is going to be monoarthralgia. Next comes a doubt on the fever. The fever, it is greater than or equal to 38.5 degree. Here it is going to be 38 degrees. Next is the ESR. ESR is going to be, in case of the low risk population, it is going to be greater than or equal to 60 mm, and this is going to be in the first hour. And then we also have the CRP. The CRP is greater than or equal to the 3 mg per dl. Next is, in case of the high risk population, it is going to be the ESR, which is greater than or equal to the 30 mm per hour, as well as the CRP being greater than 3. So here it is 60 in low risk, and in case of the high risk population or the moderate risk population, it is going to be greater than 30. Next is there is also going to be the prolonged PR interval, which is common in both. That is prolonged, this is all minor criteria, prolonged PR interval, which is common in both, and after accounting for the age variability. Now let's look at the diagnosing criteria. So we just saw all the points which are covering. So the diagnosis is done only if for the initial ARF. So in case of the initial ARF, there is supposed to be two major criteria. So there is going to be the two major criteria, or there is going to be one major plus two minor criteria which is to be followed. Or the diagnosis of recurrent ARF. So in case of recurrent ARF, there is going to be the two major or one major and two minor or three minor together. So here it is one major, two major, or it's going to be one major plus two minor. In case of recurrent, it is going to be two major, or it is going to be one major plus two minor as we discussed, or it can also be the three minor features. The next topic we are going to look at is the Duke's criteria. So this is also very important. So what happens in the Duke's criteria? So in case of the Duke's criteria, this is going to be the modified Duke's criteria, the diagnostic factors. So there is a pathological criteria, and what we other need to know is the clinical criteria. So there are two criteria, and for this Duke's criteria, you can either go by two major, or you can go by one major plus three minor, or you can go by 5 minor. So Duke is nothing but Dukes. So there are 5 letters. So there is 5 minors which can be done. 1, 2, 3, 4, 5. So 5 minors or 2 majors or 1 major and 3 minors. So let's quickly look at just the headings of the Duke's criteria. So there is a pathological criteria. So as far as the pathological criteria is concerned, there is the microorganisms which have to be identified in the context of the clinical signs of active endocarditis in one of the followings. So you can have microorganisms identified, that is vegetation, cardiac tissue, explanted the prosthetic valve, and so on. And next is the active endocarditis in case of the active endocarditis. First is the microorganisms which are identified in the context of clinical signs of active endocarditis, and next is the active endocarditis in any of the following. So this microbiology, it is identified by the PCR, amplicon, the metagenic sequencing, or the in situ hybridization. Next is the clinical criteria, that is a major criteria. So in case of the major criteria, you have microbiology. Microbiology, you look for the positive blood culture. The positive blood culture, next is the positive lab test. So these two are done. Next is, so in case of the positive lab test, there can be a positive PCR or the Coxiella burnetii antipase 1 Ig, or the indirect fluorescence assay. So this positive laboratory test, it is divided into three. That is, it can be the positive PCR, it can be the Coxiella burnetii, as well as the indirect fluorescence assay. So three aspects. So in case of the blood culture as well, it is isolation of the organisms which commonly cause, or the isolation of the organisms which occasionally cause or rarely cause. So next is moving on to the imaging. So under imaging, we look for the echocardiography as well as a cardiac CT imaging, and then we also look for the PDG PET or the CT imaging. Next, looking at the surgical, the intraoperative evidence of the IE, such as vegetation abscess or the valvular destruction. So this is nothing but the intraoperative evidence of the IE. Next is we move on to the minor criteria. You have the minor criteria. So what is the minor criteria? Minor criteria, we have the predisposition. So minor criteria, there's predisposition, then that is previous history of IE, the presence of prosthetic valve, the valve repair, and so on. Next is the fever. Fever is where there is a greater than 38 degrees Celsius. Next we look at the heading of vascular, the major arterial thrombi and so on, and the immunological evidence. We look at the immunocomplex, that is mediated glomerulonephritis, the osseous nodes as well as the rod spots, and the positive rheumatic factor. Next is the microbial, that is a positive blood culture for the organisms that is consistent with the IE and the meeting the major criterion requirements, or we also go for this is the microbiological, as we discussed. It is can also be the PCR or the amplicon. Next we move on to the imaging. So what are seen in imaging? So in case of imaging, you have the PET or the CT. So imaging, we have the PET or the CT. That is the evidence in less than 3 months of the cardiac surgery. Next is the physical examination. There is a new auscultations or the regurgitation murmur when the echocardiography is available. So we have the physical examination as well. So this was about a brief about the Duke's criteria. Next we move on to the vegetations of the various types of endocarditis. So this is nothing but the vegetations of the various types of endocarditis. So first is we look at the RHD, that is a rheumatoid heart disease. So here the vegetations are, it is small, it is firm, as well as it is friable. Next is the site is along the line of closure. So it is along the line of the closure. Next is it is sterile or infective. So the answer is it is sterile. And embolism, it is not common. So this was about the RHD. RHD is, it is along the line of closure. And it is small, firm, as well as friable, and it is along the line of closure. Next we move on to the infective endocarditis. So what is the IE? That is infective endocarditis. It is nothing but it is large, bulky, and friable and destructible. It is large, it is bulky, it is also friable as well as destructible, and it is seen in the cusp of valves. There is a mural endocardium. So infective endocarditis is seen in the cusps of valves. So cusp of valves, that is a mural endocardium. So is this going to be sterile or unsterile? RHD was completely sterile, and this, that is the infective endocarditis, is going to be non-sterile. It is NS, that is a non-sterile. Next is the embolization. So the embolization is going to be, it was uncommon in case of the RHD. There is a rheumatoid heart disease. In case of the IE, that is infective endocarditis, it is going to be very common. This is going to be very common. Next we move on to the non-bacterial thrombo or the non-bacterial endocarditis. So what happens in the non-bacterial thrombo endocarditis? So here the etiology is it can be occurring due to the malignancy. By malignancy we mean the M3AML or the pancreatic carcinoma. So all these factors can contribute, or it can be the venous thrombosis, or it can be the Trousseau's syndrome. So how are these conditions in case of the non-bacterial endocarditis? It is nothing but it is single. So when we saw the RHD was small, warty and friable. It is along the line of closure. Infective endocarditis is present in the cusps, and the non-bacterial endocarditis is small, it is single as well as it is multiple, and it is non-destructible. And this is also seen in case of the line of closure. And is it sterile or non-sterile? The answer is it is sterile. And the non-sterile was nothing but the infective endocarditis. And is it common? The answer is yes. The embolization is very common. It is common for the embolization. Next we move on to the Lyman-Sack endocarditis. So Lyman-Sack endocarditis, we call it as the LE endocarditis. The LE endocarditis is seen in case of the systemic lupus erythematosus, it being one of the major causes. So how are the functions? It is nothing but it is small. It is small to the medium-sized flat. It is medium size, as well as it can be flat, or it is verrucous. And how are the structures? Where is it aligned? It is either on both sides of the leaflets. So this is a Lyman-Sack endocarditis. So this is on both sides. So it is present on both sides of the cusp. So it is both sides of the cusp and the both sides of the weave leaflets, not the cusp, the weave. To be specific, it is the valve leaflets. Next, is it sterile or non-sterile? The answer is it is sterile. And what about the embolization? Embolization is going to be uncommon. So to quickly recap, the image-based questions are very important in this case. So let's repeat again. So in case of rheumatic fever, it is along the line of closure. So line of closure, LOC, along the LOC. Next we move on to the infective endocarditis. The IE, infective endocarditis are large irregular masses on the valve cups. So they are large. Infective endocarditis are large, and this is on the valve cusps. Next is we look at the non-bacterial thromboembolitis. The non-bacterial thromboendocarditis. So this is nothing but a small blunt vegetation that is greater than 1 centimeter. That is the line of closure. So it can be along the line of closure, and they are nothing but it is large. So that is the difference. And next is the Lyman-Sack's endocarditis, and this, as we discussed, it is present on the both sides, either or both sides of the valve leaflet. So it can be here or it can be on the back as well. So both sides. Next, let's quickly highlight what is the HCM. The HCM stands for the hypertrophic cardiomyopathy. It is nothing but it is autosomal disorder. It is nothing but it undergoes the missense mutation. So there's a missense mutation. It is the most common mutation, that is the beta chain of the myosin. So there's beta chain of the myosin, and the myofiber disarray on the histology. So it has a myofiber disarray on the histology, and the diastolic dysfunction is present. So there is diastolic dysfunction which is present. So on echocardiography, the left ventricular wall thickness is greater than 15 mm. The systolic anterior motion of the left wavelet is seen, and the banana shaped left ventricle can also be seen. So let's quickly write in case of the echocardiography. The left ventricular wall thickness is going to be greater than 15 mm. Next is the systolic anterior motion of the left leaflet, as well as the banana shaped left ventricle. Then there are some causes of the cor pulmonale. So causes of cor pulmonale, it includes the diseases of the pulmonary parenchyma. So a disease of the pulmonary parenchyma is nothing but the chronic obstructive pulmonary disease. That is, it includes the COPD, it includes the diffuse pulmonary interstitial fibrosis, diffuse, pulmonary interstitial fibrosis, it includes the pneumoconiosis, as well as the cystic fibrosis, as well as the bronchiectasis. So all this is involved. Next we move on to the disorders of the chronic alveolar hypoxia. So the disorders of the chronic alveolar hypoxia. So under this there is obesity hyperventilation syndrome, the central hyperventilation syndrome, the neuromuscular respiratory failure, the chest wall abnormalities, that is kyphoscoliosis, as well as the chronic exposure to the high altitude. Next is the disease of the pulmonary vasculature. The disease of the pulmonary vasculature. So this includes the PAH, that is the pulmonary artery hypertension, that can be idiopathic. So it can be idiopathic, it can be hereditary, it can be drug or toxin induced, and the veno-occlusive disease. Next is the chronic thromboembolic pulmonary hypertension, the pulmonary thrombotic, the chronic thromboembolic pulmonary hypertension, or the pulmonary tumor thrombotic microangiopathy. To watch more videos like these and grow daily, subscribe to the Dr. Hub channel.